So it's a great pleasure to be with you today. We're going to present TAVI Life in a Box case from the American University of Beirut. I'm Fadi Sawaya. I'm with my colleague Ziad Ghazal. We're going to do a portico case with the new FlexNav system. So we have a 68-year-old lady who's frail, who's a heavy smoker, who was diagnosed with lung cancer stage 3, had chemotherapy and radiotherapy, is in remission, and she has a normal kidney function, normal EKG. She was referred for us because she has dyspnea on exertion. We did an echocardiogram. It shows very severe aortic stenosis with a valve area of 0.7 and mean gradient of 64. Her ejection fraction was normal. She has a low SCS and Euro 2 score, but because of the radiation in the chest, she was a surgical turn down and referred for TAVI. And this is the TTE showing a mean gradient of 64 with a round contour consistent with severe aortic stenosis. This is her coronary angiogram, showed non-obstructive coronary disease. The LED and circumflex are free of disease or significant disease. And also on the spider view, non-obstructive coronary artery disease. And the right coronary is small with non-obstructive CAD. We did an angiogram of the right iliac and the right common femoral at the time of the angio, and it showed a patent vessel around 5 to 5.5 millimeter. So we did the CT of the TAVI protocol, showed very wide sinuses of 30 to 31, good left main height of 13.9, annulus size of perimeter of 75 with a min of 21.2 and a max of 26.2 and a perimeter derived of 23.8. Now VOT diameter is the same, around 74 millimeter. The STJ junction is around 25.5 millimeter. The sinus height is adequate with the right coronary height of 16.9. We did the 3 angio view where the 3 cusps are together and shows LAO 14 cranial 9 with even calcification between the 3 leaflet. The right cusp overlap and left cusp overlap showed an angle in RAO 5 and caudal 11. And this is the distribution of calcification. For the portico valve, I don't usually like to use the cusp overlap because in this valve, you don't want to go very high. It's not funnel shaped like the Medtronic valve. It's tubular, and you might not get adequate sealing if you go very high and you cannot post-dilate. So the plan is TAVI due to chest radiation, and the clinical indication is symptomatic severe AS. Our procedure strategy is ultrasound-guided right and left femoral access. There's no radial access. There was a radial artery occlusion from prior cath. Years ago, we're going to do a valvuloplasty with a 22 by 40 Z-Med balloon, right femoral TAVI with the new FlexNav 27 portico. We went with 1 ProGlide in the middle with a bailout of 6 or 8 French angioseal. So just a quick update about the FlexNav delivery system. What's new about it, that has a very reduced insertion profile. It's sheathless system like the Medtronic system, like the Evolut R and Pro, and it has a very hydrophilic coating. So in the TAVI world, this is the smallest inner and outer diameter. It's 14 for the 23 and 25, and it's 15 for the 27 and the 29. So as the inner diameter, it's the lowest in the market, smaller than the Evolut R system. What's new about the system, the old system was very unstable during deployment, and they added a new stability layer that makes the deployment easy. It tracks very well, and it's a very flexible system. And the handle is very ergonomic. It has simplified steps. It redesigned the lockout mechanism and the retainer release improvement, and I'll talk about it later. So you have the delivery handle in the back. The handle 1 is where the guide wire lumen flush port goes. Number 2 is the micro slide button, and the 3 is the micro adjustment wheel if we're trying to resheath the valve. Second, in number 4, you have the wheel which you deploy and resheath. And 5, you have your lock button that will explain while deploying. And number 6, we have a deployment indicator to know how far we are with the deployment. So in 7, we have the valve capsule flush port. In 8, we have the stability layer flush port. And 9, the stability layer I talked about. So as I said, it's an integrated sheath like the Evolut system, so we don't have to put an 18 and 19 French sheath like in the old system. We're gonna pace from the wire today. We're not gonna put a pacemaker. So I put just the micro puncture wire through the left femoral vein, and this is gonna serve as my microglide 6 French sheath that was upgraded to a 14 French sheath. I already crossed the ventricle. I have the pigtail in the LV. I have a pigtail in the aortic valve, and we have a gradient of at least 50 peak to peak, which is consistent with the echo. So what we're gonna do now, we're gonna take a 22 balloon. The mean derived is around 23.3 or 4. The minimal diameter is 21.7. So the usual balloon is 22 millimeter compliant. So now I'm gonna take my confida wire and I'm gonna put it at the apex. Okay, perfect. Do an injection. The angle will inject. Okay, it's not too bad. We're gonna according to the capsule. You see the right is in the middle. It fills late. We have the tail and the non-coronary cusp and the left coronary cusp. Okay, so we're gonna go with the ZMed 22 balloon. Push the wire a bit, please. Okay, perfect. So the wire now is good in the apex. We're gonna go with a 22 by 40 ZMed balloon. Okay, so we're gonna now attach the I'm gonna scrape a bit here. So let's test pacing. Okay, a max is balloon. Let's go 180. Okay, adequate capture. Go up. Okay, and down. And off pacing. Okay. So this is the valve. This is the FlexNav system. Very flexible nose cone. This is where the valve is cramped. This is the inline sheath. This is the extra stability layer. This is the very ergonomic handle. You have a tactile. You have an indicator for how much you've unsheathed. You see the blue line will go into will cover the white line until the gray line, and this is when the safety button will pop out. So the blue handle is your wheel that you unsheath and resheath, and this is your resheath at the end after you deploy, and this is your fine adjustment wheel that in case you resheath and you still have a gap. Okay, so I'm gonna repeat. This is nose cone. The valve is crimped within this. This is the integrated very hydrophilic sheath. This is the stability layer that makes the deployment easier. That will unsheath, and as we go with the unsheathing, this blue indicator is gonna move towards here. When we arrive around 70%, we're gonna hit the safety button. We're gonna have to push it. Now we'll see how this is the fine tuning. So this is an extremely flexible system. You're gonna see how it's gonna track beautifully across the aortic arch. And now we cross into the ventricle. What I'm gonna do, I'm gonna readjust my tail. It's stuck behind the valve, and I put it back in the non-coronary cusp. Okay, so you see there's a black dot. So this black dot, usually we put it at the end of the annulus, and this is where we're gonna start sheathing. Can we paste PVCs. No, it's okay. So now I'm just spacing to remove all these PVCs and have a more stable deployment. Okay. So now Ziad is going to start to unsheath, and you can see this is the knob. It's very easy, ergonomic, and very easy to do. Okay. So we'll have to go slow at the beginning. Actually, we'll unsheath from the capsule, and then we'll go very slow. So now the capsule is coming out. The target in this valve is not 2 to 3 millimeter like with the Medtronic. It's more 5 to 6 because it's smaller. And it has relatively, stop here, a low radial opening force. So if we're going to post-dilate, it might pop out. Who has the injector? Inject. Okay, that's beautiful here. Do one turn. Okay. One turn. Can we pace at 120, please? One turn. 130, please. Okay, one turn. You see, it's not moving at all. So where I started, this is the beauty of the system. It's very stable during deployment. One turn. Inject. Okay, I think it's not bad. Okay, keep going. One turn. One turn. One turn. Can we pace at 150, please? Okay. Go for one turn. One turn. One turn. One turn. Go all the way to the one turn. Go, go, go. Go, go, go. Go to the hard stop. Hard stop and stop. Pacing 10. Okay, let's adjust. Okay, stop pacing. We're very hot on the left side, so I bring it a bit lower. So Dr. Hazal is resheathing here. System, so don't. Keep going, keep going. And stop. Basically. The partial repeat. I pushed it a bit at 1 millimeter and then I but it's square, it's well, you have around 5 to 6 millimeter at the non-coronary cusp. At the left coronary cusp, we are 3 millimeter. At least now we know we're in a more stable position. Okay, I'm gonna wait a bit. I'm gonna wire just a tad to remove all the tension. Okay. So here, just button. So now we cannot. This is the safety button. Okay, this is safety. So I'm gonna press it, and I'm just gonna unsheath a bit more and wait a bit. Okay. Inject. Okay. Yes. Your handle is here. Okay. Yes. Start, but very slowly. some forward pressure, but not too much. Yeah, I'm gonna keep the pigtail and then we'll remove it later. Okay. Keep turning slowly. Okay, keep turning. So in the portico, there's 3 tabs. So you want to make sure the 3 of them are disconnected. Go to a hard stop. Go. Okay, so I'm going to do a sweep. It seems one seems to be still attached. No, these are the 3. I'm going to do a cine. 1, 2, 3, detach. I'm going to push my wire here. After I push the nose cone. Okay. So I'm going to mag down. So now to resheath, what we're going to do, this is the micro handle. I'm going to keep my left hand straight, and I'm just going to resheath like this, okay? It's very easy. Here, I think I don't want to oversheath. That's good. Okay. Who's on the injector? Inject. Okay. But it's very little. Okay. Yellow. Go up with the balloon. All the way, all the way, all the way. Okay, pacing down. So we're gonna take our last injection, inject. Okay, so the leak is it's a perfect position, no leak, normal. Do a beautiful case where we demonstrated in a young patient with the need of coronary access in the future to use an intra-annular valve. We used the portico system 27 with the new FlexNav system, and we had no paravalvular leak after post-dilation. We had no new left bundle branch block. We had adequate closure in a very difficult calcified vessel. We had no gradient. I think we did good for this patient. Excellent.